Can we now invite our second speaker, Dr. Arun sir, MBBS, DNB Pediatrics, DM Gastro. A small answer.
Dr. N. Arun, DNB Pediatrics, DM Gastroenterology, Education, DM Medical Gastroenterology, Stanley Medical College, Chennai 2015 to 2018, DNB Pediatrics, Indira Gandhi Government, General Hospital and Postgraduate Institute, Puducherry 2008 to 2011, MBBS, Rajamathaya Medical College, Annamalai University, Chittenborough, 2000 to 2006. Work history: 1 visiting consultant gastroenterologist, hepatologist, and interventional endoscopist, Venkateswara Hospitals, Chandler's Road, Nandanam, Chennai. 2 Chandra Gastro, Liver and Endoscopic Center SEP, 2019 to till date. Consultant gastroenterologist, hepatologist, and interventional endoscopist, Chennai. 3 Assistant Professor Aug, 2018 to Aug. 2019. Medical Gastroenterology, Rajiv Gandhi Government General Hospital, Chennai. 4 Senior Resident 8-2017 to 7-2018. Department of Medical Gastroenterology, Stanley Medical College, Chennai, Tamil Nadu. 5 Junior Resident 8-2015 to 7-2017. Department of Medical Gastroenterology, Stanley Medical College, Chennai, Tamil Nadu. 6 Senior Resident 6-2012 to 7-2015. Kanchai Kamakodi Child Trust Hospital, Chennai, Tamil Nadu. 7 Senior Resident 7-2011 to 5-2012. Indira Gandhi Gov. General Hospital and PGI, Puducherry. 8 Consultant Gastroenterologists, Hepatologists, and Interventional Endoscopists, Apollo Main Hospitals, Greens Road, Chennai. Accomplishments: original research article and abstracts and posters in national and international level. Conferences and seminars. Presented many cases in state conference. Attended World Congress of Endoscopy. Presented many nationalized talk and webinars in state and national talks. Affiliations: life member in Indian Society of Gastroenterology. Life member in INASL. Life member in SGES. Life member in IAP. Life member in IJPP. Skills: expert in all invasive and non-invasive procedures in gastroenterology. Dedicated to excellence. Good clinical judgment. Humane and respectful. Calm under pressure. Medical research comprehension. Strong interpersonal skills. Peer support.
Hand over the session to you, sir.
Thank you, Dr. Subhash, for your fantastic lecture. And respected professors, senior consultants, and my dear friends, it's been really a great pleasure for me to be in this wonderful gathering on this Sunday. I would like to thank Team IMA Metro who gave me an opportunity to share some knowledge and inspect what's happening in the field of gastroenterology regarding management of gastroesophageal reflux and acid peptic disorder. See, this is very, very common scenario what we are executing in day to, everyday's life. Even physician, surgeon, gastroenterologist, everybody will be experiencing this kind of presentation, and you are not going to leave your OP practice without this kind of event. To discuss about this, we should know the basic definition. As we all know, gastroesophageal reflux, any contents, if it is going to get refluxate from your gastric region into your esophageal tract, there's nothing but your gastroesophageal reflux, that based upon your classification, what is known as Montreal's. What is going to happen once a patient is going to exhibit? See, if you're going to look into the data in Indian scenario, almost around 9 to 20% of the population will be experiencing, and the prevalence will be more common in Europe and US and compared to your Indian scenario because of the diet and lifestyle pattern. And to whom the patient is going to seek a gastroenterologist's opinion. So initially the patient will be consulting with the basic physician practitioner, followed by even in the tip of iceberg, the still remains uncommon because as the patient scenario is not going to improve with your PPI antacids and all those medications, followed by once the patient is going to not adhere to the medication for longer duration, and this kind of patient is going to seek a gastroenterologist for further management, and it always remains the tip of iceberg. And once the patient is going to develop a chronic and persistent symptoms and complication, that's the area you need to refer to the gastroenterologist promptly. And in OP practice, 40% of monthly visits and 20% of weekly and 4 to 7% of daily visits will be because of your GERD and reflux. So we should not forget any patients, even with atypical chest pain, as we have been discussed with the previous speaker. So the various causes of chest pain, one common scenario we are not supposed to forget is gastroesophageal reflux, because that is very commonly we are encountering, and most of the time when you are going to treat a patient, within a span of time, even after stopping the medication, the patient will be bounced back again with this kind of event. So how are you going to assess, how are you going to manage, what is the dose, and what to whom you are going to refer, how this patient going to get intervened with the diet and lifestyle modification is the most important thing for me to address here over a period of next 30 minutes. As we all know, to briefly, my intention when we are going to wind up the session, we need to know something about what is happening in gastroesophageal reflux. So the basic pathophysiology, how are you going to approach and how to diagnose, how are you going to investigate, followed by what is the basic lifestyle modification and treatment, what are the new approaches being tried in the field of gastroenterology when you're going to manage a patient with gastroesophageal reflux disease. So the four basic mechanism is one by your esophageal tract, and one by your lower esophageal sphincter competence, and one by your gastric emptying. So the lower esophageal sphincter competence has to be well augmented if you want to prevent. So this is a basic outline of your pathophysiology, what is happening in your GERD. See, starting from head to foot, starting from a salivary function, if it is going to get impaired, if your esophageal clearance, if it is going to get impaired, followed by the patient is going to have iatrogenia. As you all know, iatrogenia is very, very common scenario if the patient is going to obese and sedentary lifestyle. So these are all the patients will be having common scenario of iatrogenia, in which there is various grading. Zales grading 1, 2, 3 is so once a patient is going to have iatrogenia, if the TLS, if the inappropriate relaxation of your lower esophageal sphincter and various acids, your gastric acid and your pyloric incompetency, one is because of your pyloric incompetence, dural incompetence, and esophageal mucosal defense, everything, if it is going to get impaired, and your reduced resting pressure of the LES, if it is not going to get augmented properly, and that's the area for your that's the area for your refluxate events to take on. The main thing, the four major mechanism is your LES competence, that was by your TLSER, and your swallow-induced relaxation, your hypotensive lower esophageal sphincter, as well as your iatrogenia. So what is this LES, transient lower esophageal sphincter? So our intention, we need to reduce the sphincter relaxation. Only then we can able to prevent the reflux. So if the sphincter relaxation, if it is going to get augmented for a period of more than 10 seconds, and if the 50 to 80% of the reflux events is going to get involved because of this, because of mechanism of belching, your vagal receptor, your stretch receptors, all those things, if it is going to get stimulated, that's the area that is high prominent for the patient to land up with reflux. And you are going to take a swallow. The swallow induced relaxation, once your hypotensive lower esophageal sphincter, it is going to get augmented, and the iatrogenia, what I've been discussed with you. These are all the various areas of your common presentation. The most common symptoms is heartburn and regurgitation. Most of the patients, around 70 to 80% of the population, once they're going to land up with evidence of GERD, they're going to have this common scenario. But it usually occurs shortly after eating and can last from few minutes to hours. The patient may worsen with swallow. See, this is the basic classification of your GERD. Always you should remember that not only because of your esophageal symptom, also your extra esophageal symptom has to be analyzed, because both of them is going to carry out with a common innervation arc. And esophageal symptom is nothing but your typical reflux and your esophagitis and all those things, and your extra esophageal based upon your extra GI source like cough, laryngitis, asthma, pharyngitis, sinusitis. There are so many etiological other triggers to be looked into that. And basic diagnosis. See, how are you going to diagnose this GERD? See, there are patients to whom you are going to refer. How are you going to diagnose? At what point of time this patient has to be prompted? A barium swallow, is there going to have any use? Not much of role for barium swallow nowadays, except for evidence of achalasia or some other things, what have been previous speaker been discussed. That's the area you can try. Apart from that, identifying a predominant role of GERD with barium swallow, not much of concern nowadays. Endoscopy definitely having a significant role, and pH monitoring, that's one of the very important potential investigation. And esophageal manometry, once you're going to diagnose your motility, your neuromotility disorder, once a patient is going to land with achalasia and various other based upon your modified Chicago classification, is what's happening. So there are your list of that, it's a motility based disorder. At that point of time, you can consider for esophageal manometry, because in that area also the patient may land with evidence of GERD. And any patient, when you are going to refer to a gastroenterologist with this kind of presentation, always the red mark signs, mean her red flat signs, you're not supposed to forget any dysphagia or enophagia is very common indicator to refer promptly to endoscopic evaluation, and significant weight loss if it is going to be more than 5 to 10 percentage, and once the patient is going to have evidence of GA bleed, anemia or mass or stricture or ulcer if you are going to be diagnosed. So always peptic ulcer disease, we are not supposed to forget peptic ulcer and GERD will always go together, because peptic ulcer, the area of treatment is entirely different, and even then we are going to put the patient on PPI doesn't mean the peptic ulcer is going to get healed off. So GERD and peptic ulcer is a different entity that should be addressed in proper way. And you need to screen yourself for Barrett's esophagitis. Barrett's esophagus, that's one important thing in which your esophageal squamous epithelium, if it is going to get replaced by your columnar mucus of your stomach, there is high potential for you to develop evidence of adenocarcinoma as the day progresses. So in case the patient is going to land up with persistent vomiting, these are all the various red flag signs that we are not supposed to forget. These are the patients to be promptly referred to a endoscopic evaluation. But upper GI endoscopy, we need to have evidence of alternative diagnosis care. For example, your esophagitis grading is there. For Barrett's esophagus is very important for in case to identify your peptic stricture. Once the patient is going to land up with evidence of peptic stricture, it could be, see, you should not forget there are two etiological focus for stricture. One is because of benign stricture and one is because of malignant stricture. So benign stricture, the basic common etiological factor in Indian scenario will be always mainly because of peptic. So peptic stricture, the various modalities of treatment are available. You can go for steroids, you can go for dilatation, various dilatation procedures in which nowadays there are stent and other modalities have been developed. So, and low grade esophagitis, that's also one of the indicator for which we need to look into that. Endoscopy. And based upon your endoscopy, you need to classify the patient as non-erosive and erosions if it is there or not. Because every time when you are going to see a patient with evidence of endoscopic events, most of the time the patient may be having evidence of distal esophagitis or antral erosions. So distal esophagitis means we need to categorize the patient with grading as per your Los Angeles classification. And even if the endoscopic reports are absolutely fine, doesn't mean the patient does not have evidence of gastroesophageal reflux, because non-erosive reflux disease is very common in Indian scenario that we are not supposed to forget. More than 60% of the population, mainly by your NERD. And this is the basic classification for a gastroenterologist that we are not supposed to forget. When you're going to look in your endoscopic picture, the first imaging, always the very common one single mucosal break, what is called as Los Angeles grade A, if it is going to less than 5 mm. And if it is going to be more than 5 mm, that means the patient is going to be in Los Angeles grade B. And if it is going to involve a circumference but not more than 75% Los Angeles grade C, but if it is going to extensively involve, which means multiple erosions which is going to happen in the esophagus, that means Los Angeles grade 3, grade D. Why we need to assess this grading is very important, because based upon the grading we need to treat the patient, to which medication we need to start and how long we need to give, how is going to follow. These are the various indicators for which the basic endoscopic evaluation for a patient who presents to us in the background of GERD is very, very important. And esophageal biopsy not absolutely indicated. Once esophageal biopsy, when you are going to suspect any evidence of carcinoma, there is absolute indication. But even then, if you are going to put the patient on, PPI, the patient might be having evidence of refractory GERD. There are a huge list of causes for refractory GERD that I will be taking over in the upcoming slide. But once a patient is going to have refractory GERD, if you are going to suspect evidence of eosinophilic esophagitis, because this eosinophilic disorders right from your oral cavity into your anal canal, it's being frequently encountered nowadays. So we should not forget, not all patients who present to us or think only in terms of gastroesophageal reflux. It could be because of eosinophilic esophagitis, for which we need to look into a biopsy to look for evidence of eosinophilia and all those things. And based upon your atopy, your skin, all those dermatology manifestations, your apart from your colitic presentation, all those pointers to be taken into account if you want to diagnose esophageal disorders. And esophageal manometry, no major role to diagnose esophageal GERD, but you can try because whenever you're going to plan the patient for any anti-reflux surgical procedures, at that point of time, there is a role for esophageal manometry. This one potential impedance pH monitoring is important 24 hours. You can do it by a catheter based, or you can do it by a Bravo capsule. There are so many modalities are there, and nowadays impedance combined impedance monitoring is there. So what we are going to do, we need to place a catheter into the lower esophageal junction in which we are going to assess how far the reflux event is going to get happened. So there are various scoring systems there, and what we are going to call as D-MISR score, in which always we need to see if the score, if it is, always our main intention when you are going to treat a patient with GERD, we need to maintain a pH should be, gastric pH has to be elevated more than 4. So how much of time if the pH is going to remain less than 4, that's one of the most important thing we need to assess by your D-MISR scoring. If it is going to be more than 14, that's strong pointer for you to consider the reflux if it is happening or not. Because based upon your esophageal impedance monitoring, you can able to identify whether the patient is having a worsening of event or non-worsening event, whether the patient is going to have a proven GERD or unproven GERD. If you're going to look into this slide, see, once you're doing upper GI endoscopy with atypical symptoms or all those things, at that point of time, what you're going to do, you need to do a catheter-based or wireless pH monitoring or 24 hours impedance pH monitoring. Either you need to subject the patient with PPI therapy or off PPI therapy for a duration of 1 week to assess whether the patient is responding or not. And based upon that, we need to calculate your total acid exposure time. This is very, very important when you're going to look into your pH monitoring. And acid exposure, if it is going to be more than 6, is always inconsistent with GERD. If it is going to be less than 4, possibility of normalcy will be there. And number of reflux episodes is, if it is going to be more than 80, it's abnormal. So more than 6 and more than 80 of reflux, we should not forget, based upon your manometric, based upon your esophageal, your scoring system, pH metric system. So based upon that, 80 more than 6 and reflux more than 80% is always considered abnormal. And multi-channel luminal impedance, in which we can use this system also, because see, as we all know, the reflux will happen not only in liquid, even in gaseous state or semi-solid state. So even in various states, you can able to identify based upon this multi-channel intraluminal impedance. The sensitivity is almost going approximately around 70 to 100%. So even for the forward flow and even for the antegrade flow of your reflex, and it can able to identify the height of your reflex, and based upon that, even in non-reflex episodes can be useful to identify, and this modality, combined modality, can be tried. And nowadays, no need to place a catheter. You can try with your Bravo pH capsulometry, in which what you are going to do, this is wireless radiotelemetry probe. What we are going to do, you need to place a capsule just 5 centimeter OG junction, in which if you are going to identify with that, you can able to identify the signal. But it's very easy, not much of difficulty. But even though if you are, the only main problem for this kind of patients, you need to wait for a duration of almost around 48 hours. And in case if you are going to remove within a span of around 24 hours, you couldn't be able to document the period of reflux, how much of events is happening. And the main area for us to discuss today is GERD management, because GERD management day in and day out will be having more common doubts. Any patient gastroesophageal reflux, as per American ACG guidelines, the first and foremost thing, lifestyle modification. Lifestyle modification, as we are well known, frequent small meal and avoidance of high carbohydrate, high fatty meal. And apart from that, you need to sleep in left lateral or not to be in prone position, and diet and physical activity at least 4 to 6 hours in a day. But once you're going to take care of your diet and lifestyle modifications, doesn't mean your reflux is going to get prevented. Because even with your diet, even with your lifestyle modification, there is high possibility for this kind of patients to develop your reflux, that as per various papers and various evidences there to go. But even with that, our diet and lifestyle modification has to set a primary aim to target the patient with improving your reflux episode. Because once a patient is going to have a high obesity, in which at that point of scenario, your cytokine levels is going to go high, and at that point of scenario, there might be evidence of your early special fit is going to get augmented, and that there is high possibility for this patients to land up with worsening of GERD. So diet, lifestyle is one important thing, and followed by the basic medications. If it is not responding, stepping up and stepping down, and finally we can go for surgical intervention or endoscopic advanced line of modalities of treatment. So basically, we need to start with the patient with single dose PPI. If it is not responding, we can go with double dose PPI therapy. And even then, if the patient is not going to show any evidence of response over a period of 8 to 12 weeks of duration, we need to consider this patient as refractory GERD. Refractory GERD is one separate area that will be discussed in a separate forum, because it's such complex scenario. So many etiological factors are there to assess your refractory GERD. But to brush up our knowledge about the basic symptoms, First, we need to do upper endoscopy to identify any evidence of any specific focus like eosinophilic esophagitis or any erosive esophagitis as per that. And once the patient doesn't have any evidence of typical symptoms, you need to focus on your atypical symptoms. And if you're having any suspicion or even your respiratory, your ENT, all those things to be analyzed. And we need to do a pretest probability based upon on medications or off medications based upon your impedance pH monitoring, and you can able to identify the reflux events as what I will discuss with you based upon your acid exposure time and based upon your D-Mister scoring. And the basic thing, lifestyle model, this one thing we're not supposed to forget. Your lifestyle will be taking care of around 20%, your H2 receptors will be going to take on around 50%, and your PPA of single dose will be around 80, and your double dose, increased dose of PPA, that might be evidence of around 90, but some papers they are quoting even up to 100% of responses there, but still it's a questionable issue to be addressed more. So basically I told you, so always try to sleep in the left lateral position and avoid sleeping within a short period of time, avoid nap in afternoon hours, and you need to complete your meal by around 7 to 7:30 in night. You need to go to bed around 10 to 10:30. Smoking, alcohol, all those things, cessation, because these are all the things will worsen your TLACR. At that point of time, the patient will exhibit more and more reflux. So what we see, medication, never, always avoid. That's one of the most important things we need to counsel. And view list of medications. We all well know about the basic medications. Antacids just to brush up. The problem is we need to use frequent dosing. The basic mechanism is when you're going to use an alginate preparation, what is it going to do? It is going to form a wrap. It is going to form a wrap inside your acid pocket, which is going to happen in your parietal cell. And once the patient is going to get the acid wrap formation, it is going to get established. At that point of time, your reflex events is going to get controlled. But the problem with your antacid, various preparation like aluminum and magnesium preparations is there, in which it may land up with evidence of constipation, and some patients will have evidence of diarrhea, osteoporosis, osteomalacia, other complications are there. But it is not going to heal up your reflex. Once the patient is going to diagnose with esophagitis, and at that point of time, you are going to use this antacids, there is no potential role and it is not going to respond because the healing of mucosa is not going to happen with your antacid. So mucosal healing means we need to consider H2 receptors or we need to consider your PPI. That's very, very important. PPI definitely is having a high potential role, but the problem with PPI, there are more adverse events nowadays. More papers are being there, even for the cardiac events also. So H2 receptors, main thing is the huge molecules are there. Nowadays, the one common molecule, what we are trying is lafetudine, 10 milligrams HS, or some papers even we can go up to twice dose regimen can be tried morning. But when you're going to use H2 blockers, always we should not forget it is going to inhibit your nocturnal acid breakthrough. This is very, very important because when you're going to use your PPA in the morning, it is going to act for a period of around 12 to 24 hours. At that point of time, in night time, some patients may have worsening of reflux. The reflex may start on. So what we're supposed to do, you need to give a H2 blockers in night time to prevent that nocturnal acid breakthrough. But the problem with your H2 receptor antagonists is mainly it can show evidence of tachyphylaxis, which means once a patient is going to give a consecutive dosing for a longer duration of time, the response rate is going to come down. So tachyphylaxis is one common demerit of your H2 receptor antagonist that we are not supposed to forget, but it is very, very safe to use. The one problem is for grade 3 and 4 esophagitis, the response with your H2 receptor antagonist will not be very high, will not be very potential when compared to your grade 1 and 2. So, but the one common event is when compared to other molecules of cardiac drugs, so the interaction with your cardiac molecules will be very less, rather than rivastigmine already been removed from the market, not much of use nowadays, but nocturnal acid breakthrough to prevent esophagitis over a duration of time without major adverse events, always we need to consider H2 blockers. That is one safe molecule for even for the most complicated scenario to be considered when you are going to manage. But not in the presentation of UGA bleed or any other complications. Only if you are diagnosing with minimal reflux esophagitis, safely you can use. And various side effects as we are well known like your headache and all those things, and drug interactions is mainly by your COAPP 450 pathway. And the most important area for take on here is proton pump. See, what is this proton pump? This is it's a cell which is going to be located in your parietal cell. The main area of proton pump inhibitor, the mechanism of action is going to irreversibly inhibit your hydrogen potassium ATPase. So the hydrogen level is going to, so what is going to happen? It takes a non-acidic potassium ion out of the stomach and replaces with hydrogen. That's the role of your proton pump. So what is going to happen? We need to reduce hydrogen ions and we need to create with the, in order to avoid that, we need to block this H2 hydrogen potassium ATPase pathway. That's the main area. It is going to irreversibly inhibit. So once the patient is going to subject with PPI, the other new pockets to get formed, it will take minimum 12 to 24 hours. That's the area, so we need to think that. So that's why the increased duration of regimen. Now that's why the sustained release preparation nowadays is there in the market, and your extended release, your double dose regimen has been already been there. So in which the initial level of pH, it will always produce a gastric pH of less than 4. So initial reduction will be there and followed by a consecutive reduction over 4 to 5 hours. An initial reduction within a period of around 60 minutes to 90 minutes you can establish. So it can produce a sustained action, the various molecules, for example, your dexlansoprazole and your elaprazole, all those things which are going to consider. So the double dose mechanism of action has been well augmented nowadays when you are going to use your PPI. And these are all the common pathways. We are not supposed to forget that your gastrin, your ACH pathway, all those things is going to stimulate your parietal cell, and that's the area your hydrogen ions is not going to get activated, followed by once a patient is going to retain this, the hydrogen potassium ATPase blocker, mainly because of PPI, which is going to be taken with us. And the new list of molecule right now, latest one is dexlansoprazole, elaprazole, many other things is going there. Even other newer molecules being tried. But double dose PPI we can consider for stepping up of therapy. And this is the basic thing we should not forget: step up and step down. Start with your H2 receptors and PPI on demand and lower dose of PPI, and you can go up to your double dose of PPI. The merits already have been discussed with you all. Is we need to maintain a gastric pH of more than 4 for around 10 to 14 hours daily. The main problem is, so when you're going to use your PPA for longer duration of time, the nocturnal acid breakthrough, the efficacy will not be much, because as what I've been discussed with you, in order to prevent that, we need to add H2 receptors and so many other adverse events like your MACE, major acute coronary events. Most of the papers are being reported. Once the patient is going to subject with clopidogrel and other molecules at that point of time, based upon your COP 450 pathway, if it is going to add by your omeprazole and all those things, you're going to subject. At that point, the patient may have worsening of events. We don't know how far it is going to add. So the major acute coronary events are being well augmented by this PPI. So we need to assess to whom you are going to use, what are the various presentation, head to foot examination, what are the coexisting complications, comorbid presentation, all those things you need to assess before starting the patient on PPI. Just like that, starting a patient on PPI doesn't going to deserve anything. You are going to be in no man's land most of the time. And as once the patient been initiated with PPI, we need to give a duration of 8 to 12 weeks of minimum duration, followed by we need to assess with a successive either by endoscopic assessment or by clinical response whether it is going to happen or not. And the main role, the demerits, is not going to prevent your weak reflexes, your alkaline reflexes, your duodenal reflexes. All those things is not going to have much of potential role. Apart from that, your list of side effects is there. Like I don't know now, various papers being quoting with that. Your acute kidney injury is being well proven. Even for your chronic kidney disease, some papers. Now we should not forget any liver patient. For example, the common things as we are in practice, you might be coming with alcoholic liver disease. Once a patient is going to have evidence of alcoholic liver, and at that point of time, if you are going to use PPI, that might be having evidence of worsening of your PAMP and DAMP. What is a PAMP and DAMP? Nothing but your pathogen pattern as well as your damage pattern. Once if it is going to get augmented, at that point the patient may have worsening of your ascites, the patient may have worsening of your spontaneous bacterial peritonitis. There is the area you are going to make a florid growth of your septicemia and other things to take on. So always, any liver patient, be very cautious when you are going to use your PPIs. And when you are going to use PPI for longer duration, the patient may have funding gland polyp and funding gland hyperplasia, all those things, and you may develop B12 deficiency, osteoporosis, iron loss. All of these are theoretical purpose. But why I should point out that there are huge list of adverse events for cardiac, your gastric, as well as your hepatic, as well as your renal potential is there. So be very cautious when you are going to use your PPI, and never consider this is a potential molecule just like the reinitiate. Among various PPI, the two major things, rabiprazole and esomeprazole, can be considered. For major acute coronary events, rabiprazole is slightly having more potential because of COP 450 pathway is not been well augmented with that. And next to that, your esomeprazole will be the second potential line, but your renal injury and all esomeprazole can be safely considered. And once the patient, this is being taken from the recent paper of ACG guidance, what they were mentioned is that once you're going to start the patient with PPI, all the areas is going to get response when compared to placebo. Your heartburn, your esophagitis, your cardiac chest pain, non-cardiac events, all those things is going to get respond very well. And these are all the various papers to record the beneficial role of your PPIs. And next to that, the basic thing is prokinetic. Always you will be subjecting any PPI with your prokinetic. So prokinetic in order to augment your lower esophageal sphincter tone and in order to promote your gastric entry. Various prokinetics, among them the best one is always etopride when compared to other things in my personal experience. Next to that will be cinetopride. Because etopride will be D2 antagonist, nasopharyngeal inhibitor. Apart from cinetopride, will be agonist of 5-HT1 and H3, but commonly we'll be using only domperidone to be the safer side. But why the problem is happening? Because there are a huge list of demerits are there. For example, if you're going to use metoclopramide, blood-brain barrier crossing, and domperidone also might be having some evidence of hyperprolactin and other complications. So once you need to be very cautious. And if any patient is going to have evidence of irritable bowel, because most of the patient with GARD will be having functional GI disorder as per your own criteria. There might be evidence of IBS. At that point of time, you are going to subject with PPI and prokinetic. I have seen multiple patients in our experience because with that, the patient will have further worsening of events. So we don't know whether it is because of IBS per se or whether it is because of your drug, what is the thing which is going to get involved. So always you need to be very, very cautious when you are going to subject a patient with PPI along with your prokinetic. And there are some other drugs that definitely you are going to have, you will be seeing most of the patients will be having high level of hiccups at that point of presentation. In order to improve, in order to TLAC, in order to control your TLAC, we can use baclofen, GABA B agonist at a dose of around 5 to 20 milligrams. In order to decrease it's going to come when decrease your acid as well as a diurnal reflux. These are all the drugs can be tried for a period of around 4 weeks of duration. But there are major adverse events like drowsiness, dizziness, all those things can report. Refractory GARD, I have told you many previously. Initial paper what they were mentioned at least 8 weeks, but there are some new papers what they are giving at least of 12 weeks of therapy. Double dose PPI, 12 weeks, no response, even with good adherence, lifestyle modification. Refractory GARD, look for other causes. It could be because of reflux esophagitis, NERD, or it could be because of your functional heartburn, or it could be because of hypersensitivity esophagus. All those things might be there. So many things to be considered. And newer molecules, when you're going to see, is by your H2 receptor, that what I've been discussed to prevent your NAB. That's nothing but your nocturnal acid breakthrough. And next to that, your potassium blockers. That's nothing but vonoprazole can be tried. Vonoprazole in management, newer molecule being tried in India, but still we need more papers to augment in day-to-day practice. Vonoprazole, rivaprazole, now even tegaprazole is being launched and been in trial few months before. But these are all the molecules. See, what is going to happen? It is going to block your competing with potassium. It's going to reversibly. It is going to inhibit your hydrogen potassium ATPase, not irreversibly inhibition. But when compared to your esophagitis, your Los Angeles grade C and D is going to yield very well with your vonoprazole. So these are all the molecules in pipeline in which if you are going to consider managing a patient with GARD, as the day progresses, probably it might be taking on with further thing. But always we should not forget antidepressants definitely having a potential role, because functional GA disorder, one very complex event even for the gastrointestinal. So antidepressant to whom to consider when you're going to subject based upon the CNS assessment scale and all those things, we need to consider to some extent. And if you want the patient mainly based upon your SSRI, your TCAs, and some papers have been given with evidence of fluoxetine and other support. But mainly antidepressants, there might be having some potential role when you are going to manage a patient with GARD who is going to have a refractory presentation. And these are all the various newer drugs being considered. Macrolides, even erythromycin, azithromycin being tried, and your pain modulators. So how many other new molecules being considered? Nothing much to discuss here. One few important thing before winding up this discussion is, what are the other newer innovation being happened as of now in your endoscopy? One thing is various endoscopic approaches, not only for your gastroesophageal, because the innovation in the field of gastroenterology has been gone very high. For example, your endoscopic ultrasound, for example, in your bariatric procedures, for example, in your GERD procedures, so many innovations has happened. And right now, in even main Apollo, we have been seeing many patients with this, and some patients we have been trying with this kind of modalities of management to treat. And based upon that, various modalities are there. One is by your radiofrequency ablation by stretta. These are all the patient to subject. Once the pH metry is to be proven, refractory GERD has been identified. Even with that, the patient's clinical scenario, if it is not going to respond, at that point of time, you can subject this patient with this kind of management. One is by stretta and transoral fundoplication procedure, like your esophageal. No need for any surgical intervention. The role of surgical intervention in gastroenterology has come down mostly because of this endoscopic intervention has taken on very high. And along with that, esophageal, MUSC and GE GERD procedure and anti-reflux mucosectomy. There are various, just to brush up your knowledge with that. See, this is what is going to do stretta. So you need to ablate with your radiofrequency current. What you're going to use, you need to ablate your esophageal mucosa using a mucolytic and all those things. And we need to position, inflate your balloon, followed by at that point of time, your stretta, your esophageal, the TLACI, if it is going to be well maintained. So that's the area to produce your radiofrequency ablation line of treatment. There are various side effects for that I'm not interested to discuss here, but you should not remember any GE procedures. There might be evidence of bleeding, there might be evidence of chest pain, there might be evidence of perforation. For all the procedures, we should not forget this common scenario. But for radiofrequency ablation, the risk is very, very less. This is another one, but not much of use nowadays. This bot endocrine, which what we are going to do, we are going to placate in the lesser curvature just beneath the Z line, in which we are going to apply a placator. So nothing much of use now. And esophageal can be considered as nothing but a transoral incision-less fundoplication. So what we are going to do with this instrument, we are going to apply instead of going for a surgical fundoplication procedure, and we need to augment, we need to control your lower esophageal sphincter by your esophageal mechanism. And this another one is by GERDs. That recently what I've been gone to AAG Institute of in Hyderabad. So we had a demonstration, a hands-on session for this GERDs procedure. So what we are going to use to do this, but the cost of this procedure in India as of now is around 3.5 to 4 lakhs. That's the problem, is to invest. And apart from that, we need to apply the placator, we need to open the arms, we need to fix the tissues. This is what is called as, if you're going to see around the OG junction, just beneath the lesser curve, we need to apply the helix. So what we are going to place, multiple placators we need to apply, followed by this kind of management. So we need to, mainly in the greater curvature, we need to apply this placator in order to prevent your reflux events. And various injectable materials being tried, but not much of happenings nowadays in India. But you can try any biopolymers, your polymethyl acrylate. There are so many things are there out of discussion. But you should not forget, these are all the various modalities. And one more thing is your stapler. You can apply your surgical endostapler by your Medigers, that's what's called as Muse modality for your partial anterior fundoplication procedure, and various injectable materials. And this is very important procedure nowadays being tried based upon your endoscopic injection therapy, what is called as ARMS, anti-reflux mucosectomy. So what we are going to do in this, so what we are going to, in this, what they are going to do, the application of snare over the mucosa, submucosal injection of saline is going to be done, and your complete resection of your esophageal, lower esophageal junction mucosa is going to get happen, and followed by your mucosectomy procedure is going to get complete. So that is how you need to prevent any patients, possibility of bleeding, perforation, risk are there. Links, what you are going to do, you are going to place a magnetic bed. This is the OG junction. See, you are going to place a circular ring, what is called as a links. So once you are going to place a circular ring, the reflux is going to come down. But this is all not much of based upon your magnetic attraction. Not much of papers to prove that, but these are all the areas being tried. Fundoplication, well known, the most common is Nissens, apart from the anterior as well as posterior wrap. So why I would like to point out today is, see, if you want to manage a patient with GERD, the first and foremost, assess, refer the patient promptly, functional heartburn, esophagitis, all those things, and refractory GERD, use list of causes for eosinophilic and other things to be assessed promptly, and diet and lifestyle modification, starting from your step down as well as step up approach, and with this counseling the patient on diet along with alcohol cessation, smoking, abstinence of smoking, along with basic modalities of your PPI, monitoring the dose of PPI, and endoscopic observation therapy, and all those things to be done in a prompt way to overcome this complication successfully. With this, I'm happy to rest the presentation. Thank you all for patient listening. Any doubts, any questions to clarify? Anyone?
Complication of radiofrequency ablation, fungal infection.
The radio frequency ablation, ma'am, is very, very safe procedure for most of the things in gastroenterology, because as we all know, radio frequency ablation we are using very commonly for certain conditions in India. That is only for some cases of your solitary rectal ulcer. I mean, mainly in some cases of post-radiation induced proctitis. Once a patient, for example, any patient who is having CSFX, who is followed by radiotherapy, the patient may develop proctitis. At that point of time, we are going for your APC coagulation, all those things. Like that, the radio frequency ablation has been recently well approved in India, but the risk events has been very, very less when compared to other modalities. The chances of bleeding, perforation will definitely be very, very less when compared to other modalities of treatment like your application of stapler, your muse and girdles and other procedures. So
Fungal esophagitis cause.
Fungal esophagitis is one common thing, not only for anything apart from any esophagitis. It could be pill-induced esophagitis, it could be infective esophagitis. The common scenario will be because of your infective esophagitis. Among them, viral will be more common. In fungus, we are going to look, as we are seeing, based upon your candida. That's very, very important, because candida is one common scenario if the patient is immunocompromised. For example, in diabetic scenario, we have frequently experienced that. Once a patient is going to land up with this kind of thing, so the patient will have severe odonophagia. So for grading that, we will be using staging what is called as Kodsi grading, KODSI. So what they will see based upon your velvety mucosa, how far it is going to get involved. So stage 1, 2, 3, 4. If it is complete velvety mucosa, if you're going to look into Google and things, you can able to see that. So complete velvety mucosa means the patient is having grade 4. At that point of time, some patient may deserve injectable line of treatment, and some patient we can go for fluconazole for a duration of almost around 2 weeks, at least at a dose of around 150 milligrams when you're going to subject. But fungal esophagitis, common as candida, and viral herpes simplex, we are not supposed to forget, and other viral events. Even nowadays, even post-COVID scenario, some patients be referred with the esophagitis, but we are not very sure, because these are all the things that it's been predisposing or not. But based upon the common clinical investigation and basic profile, what is there we need to treat.
Fungal esophagitis can only identify by endoscopy itself, and oral fungus also will be
you can do, without scopy, no diagnosis. Even if you are going to prove by oral, we need to show evidence in endoscopy. So without endoscopy, if endoscopy everything is fine, doesn't mean the patient is having evidence of oral lesion, doesn't mean the patient is going to have same presentation in esophagus. Because we have been seeing more patients nowadays with corrosive poisoning. 2 days before I have seen a young girl who comes in corrosive, and another patient few days before I have seen who met with RTA, just like they gone probably because of alcohol or something else. They male around almost 40 years of age. He had an injury of hyoid bone. The hyoid bone just been fractured and been evaluated by ENT and other consultant. They asked me for endoscopy. We had risk I had taken. So in Apollo, which has happened recently. So what we have done, we have just do the endoscopy. It showed even as a prominent ulceration here, but entire esophagus appears to be absolutely normal. See, whatever is happening here doesn't mean the patient is having the same presentation in the esophagus. We need to do endoscopy, but under caution.
Thank you,
The
sir.
chances of perforation is high. Thank you very much.
Thank you, sir. I request Dr. Selvarani MS ma'am to honor our speaker. Thank you, sir. Thank you, ma'am. Let us next